Yeah, it has gone live now.
Done, ma'am. Now we are live. You can start.
Okay, good evening, everyone. A hearty welcome to all of you here in India and abroad. Today, I'm Dr. Deepti Pujari here from Pune. I'm a pediatrician and an allergy consultant. I heartily welcome you all to a new webinar series on anaphylaxis. And we have an esteemed panel, a wonderful panel here to take us through this. First of all, under the aegis of Pediatric Allergy and Applied Immunology chapter of Indian Academy of Pediatrics, I welcome Dr. Neeraj Gupta, our present chairperson, the president of this pediatric allergy chapter for the year 2025-26, who is the whole soul, who is the brain behind this webinar series. I also welcome Dr. Krishna Mohan, who is the chairman for today's session, and our esteemed panelists, Dr. Vikram Patra, Dr. Narayan Modi, Dr. Suresh Gupta, and of course, we have a panelist from UK as well, Dr. Mala Raman and Dr. H. Parmesh. A very welcome to you all. Before I move forward, I would like to call upon Dr. Neeraj Gupta, who is a senior consultant pediatrician and intensivist and a big allergy name in Sir Gangaram Hospital, New Delhi. I will ask him to, Dr. Neeraj, please welcome and open the session. Please give us a small insight as to what we are thinking, what we are going to see in the next 2, 3 days regarding anaphylaxis. Over to you.
Thank you, Dr. Deepti. Thank you. That was a very nice introduction. So, welcome, friends, on behalf of IAP Allergy and Applied Immunology chapter. You might be wondering that what is there actually in anaphylaxis? Anaphylaxis is probably, you can say, like some one or two organ involvement or three organ involvement, and you have to just give epinephrine or adrenaline. That's all. So, I think that should be probably 2 lines only. That's all. So, why there is 3 webinars of 2 hours each, which is needed, and so many global experts, which is needed? So, we thought that let us try and understand this very small but very important, very critical, very crucial problem in a more detailed manner. Anaphylaxis, what we understand, is under recognized, hugely under recognized, and despite everybody knows theoretically anaphylaxis, but practical management many a times is not done in a proper manner. That is why we have planned this anaphylaxis series. So, in this series today, we will be talking about making the diagnosis and what should be done in the emergency room. Then, in the second part, means tomorrow, we will be talking about different factors, etiopathogenesis, and then the factors which are responsible and how one should proceed about diagnosing. And then in the third part, we will be also discussing about recurrent anaphylaxis, refractory anaphylaxis, and the way forward. So I think it will be a very useful series. And once again, welcome you all. Thank you very much.
Thank you, Dr. Neeraj Gupta, for giving us the insight as to what we are expecting in the next 3 days. So now it's my proud privilege to welcome Dr. Krishna Mohan. He is our esteemed chairperson for today's session. So let me quickly introduce. So it might take me half an hour to introduce Dr. Krishna Mohan. His CV is that big and vast. We talk of allergy and we cannot skip his name. It is there almost everywhere. So he's a consultant pediatrician and allergist from Kerala Government Hospital, and he is the immediate past president of Pediatric Allergy and Applied Immunology chapter of Indian Academy of Pediatrics. And if I go on, it's endless. But let me tell you, he has been faculty for lots of national and state level conferences. He has written several books. He's the chief editor. He's the in Essentials of Pediatric Allergy and Applied Immunology textbook in allergy. Then he's editor also in case-based reviews of pediatric allergy, in recent updates of pediatric allergy, and he is co-editor to many other. He has written many chapters. He has developed many modules for our pediatric allergy and applied immunology chapter. So it's my proud privilege to welcome you, Dr. Krishna Mohan from Kerala. I would really like to hear a few words from you on this topic today.
Thank you so much, Dr. Deepti, for that kind introduction. At the outset, let me thank IAP Allergy and Applied Immunology chapter for giving me this opportunity. And special congratulations to the chairperson, Dr. Neeraj Gupta, for conceiving this idea and bringing up this very important topic for a discussion both for the pediatricians. And I would like to reiterate the fact that not only for pediatricians, later we need to educate the community also regarding the importance of anaphylaxis. So thank you once again. I will be here in the meeting. Best wishes for the program, and I'm sure the moderator, Dr. Deepthi, is very knowledgeable. I know her for many years, and I'm sure today's program with the moderator and the esteemed faculties from India and abroad, today's program will be a really great academic feast. All the best.
Thank you, Dr. Krishna Mohan. It was really a pleasure to have you on board. So now let's start without wasting any more time. I call upon our first speaker for the day, Dr. Vikram Patra, to speak on anaphylaxis, pathophysiology, clinical criteria, and classification. I feel that's a very, very important topics because many of us are still not sure what, how, when, what goes wrong, why some people end up into anaphylaxis, how to classify, is it really anaphylaxis? So to solve all these queries, I call upon our esteemed faculty from Navi Mumbai, Dr. Vikram Patra, who has passed his certificate exam of excellence by European Academy of Allergy and Clinical Immunology. So he's a consultant pediatrician and pediatric allergy specialist at Apollo Hospitals and MGM New Bombay, Navi Mumbai Hospital. And again, there is a big list of his achievements. He's a core and faculty for various IIP run modules in our country. He has himself contributed to REAP module, DAD module, CADE modules, cough modules, asthma modules, and he has authored various textbooks in India as well as his faculty in various national and state level conferences. So with that, I welcome you, Dr. Vikram. Please share your screen and start the topic.
Thank you, Dr. Dipti, for these wonderful words. And before I start, let me congratulate Dr. Neeraj Gupta. So in many of the conferences, we have heard anaphylaxis a lot of time, maximum 20 minutes, 30 minutes. We have conducted a workshop on anaphylaxis. It ran maximum of 1 hour. But making anaphylaxis an affair of 3 webinars, 2 hours each, that is including 6 hours, and then community education for next 2 hours, it can be done only by Dr. Neeraj Gupta. So let me start by sharing my screen. So I have been provided the topic of pathophysiology, clinical criteria, and the classification. Basically, before jumping into the clinical aspects, in our allergy or in any condition, what we know that if we know the basics, the clinical scenario or the clinical handling of the cases becomes important. So let us start by this topic, and thank you for providing me and starting of the webinar. So first of all, as this is the first lecture of the anaphylaxis webinar series, what is anaphylaxis? Basically, anaphylaxis word came as against the prophylaxis. It is a Greek word that means ana, which is backward, and phylaxis, that is protection. Now, if we look into all the allergic disorders, the incidence or the prevalence of allergic disorders are more, and the incidence of anaphylaxis is less. But when it comes to the severity of any allergic condition, anaphylaxis is at the top level. So that's why it is very important, because understanding anaphylaxis, diagnosing anaphylaxis is very important in saving life. Then what makes it difficult? Now, in last 2 or 3 decades, approximately 20 definitions of anaphylaxis has come, and we are still studying anaphylaxis in detail. And what is being adapted or accepted all over is the WHO 2019 definition of anaphylaxis, which is a severe life-threatening systemic hypersensitivity reaction characterized by being rapid in onset with potentially life-threatening airway, breathing, or circulatory problems, and is usually, although not always, associated with skin and mucosal changes. And to increase the confusion, there are so many guidelines. Every year or alternate year, we get one new guidelines on the diagnosis and management of anaphylaxis. Why this confusion, basically? And this latest was the 2023 practice parameter update. So where is the problem? Basically, despite all these definitions, despite all these guidelines, unfortunately, anaphylaxis remains to continue to be under-recognized and under-treated, not only in our country, even in developed countries like United States. So over the years, there have been shifts and drifts in the diagnosis and management of anaphylaxis. So the need of the hour is to increase awareness, and so the idea behind this webinar series on anaphylaxis. So one of the significant shift in anaphylaxis management is the recognition of the importance of early recognition and prompt treatment. That is what is important. Initial early recognition helps in saving life. So we have different clinical criteria to have prompt diagnosis. To make the diagnosis easy, we have few criteria. There are there are multiple, but two widely accepted and used. One is that NIAID or FAAN criteria, which is there since 2006. And recently in 2020, World Allergy Organization anaphylaxis guidance came. So these two have provided clinical criteria and these are widely used. So let us go one by one. What is the difference? So NIAID FAN criteria, this is consisting of three criteria, and any one out of the three, we can prove that we can say that the patient is having anaphylaxis. So first criteria is irrespective of any trigger or the exposure to allergen. We are not sure if the patient has come to the casualty or in our clinic setup, and we are not sure about the history of any exposure. But despite that, if there is skin involvement in the form of urticaria or angioedema, and along with that, at least one of the following, either respiratory system involvement or the cardiovascular system involvement. So respiratory symptom involvement means the signs of breathlessness, wheezing, coughing, stridor, along with skin rash. You can label the child to have likelihood of anaphylaxis is more. Or along with skin rashes, if there are cardiovascular symptoms like hypotonia, collapse, or incontinency, reduced blood pressure, still we can call it as anaphylaxis. But second criteria is they've included GI symptoms also along with all this thing. In the first criteria, skin involvement was must criteria. Here in the criteria 2, if there is history of likely allergen or other trigger, means you may not get history of any allergy with the patient, but suppose exposure to a known to an allergen which is generally responsible. So if that exposure is there in this patient, uh, out of these four, skin changes, respiratory, GI, and cardiovascular, any two. So here the skin criteria is not must. So even if the child comes to us with wheezing or stridor along with crampy abdominal pain, vomiting, you still label the patient to have anaphylaxis and give adrenaline immediately. Then the third criteria, where there is past history of allergy to certain trigger or certain allergen, you know the history, parents know the history, and if that patient comes to us after exposure to that known allergen, comes to us with only cardiovascular problem, just hypotension, without skin involvement, without respiratory involvement, without GI involvement, you still label the child or the patient to have anaphylaxis. So this was widely accepted. Then in 2020, the World Allergy Organization came. So all these guidelines are to give granularity in our approach. But what is required is the unified approach. So what World Allergy Organization has come out with, they simplified. There were three criteria. Now they have combined the first two into one, and they modified the third one, and so now there are two criteria only, which has been accepted by the American Association of Allergy and Applied Immunology in 2023. So that is the latest which is there. So according to this, what they have done, in the first criteria, they've included both. So here the skin condition has become the must criteria, and along with skin, any one of the other system involved, like respiratory, circulatory, or the GI. So in the first criteria of NIAID, criteria, the skin, the GI involvement was not there. So they have included the second GI into the first. So they have combined the first and second criteria of the NIAID criteria. So here again, there is no requirement of exposure to allergen is needed. So if urticaria along with wheezing, label the child to have anaphylaxis. Urticaria with hypotension, label the child to have anaphylaxis. Urticaria with vomiting, abdominal pain, label the patient to have anaphylaxis and give adrenaline. So, and the second criteria, so in that NIAID, third criteria was if exposure to known allergen. So here it is the known or highly probable allergen. So they have included even along with the hypotension, they have also included either bronchospasm or laryngeal involvement in the form of stridor. So if a patient comes to us with exposure to any known allergen or high likely allergen and comes to us with only stridor, give adrenaline. Only wheezing, give adrenaline if there is history of exposure to any of the trigger. So be it be known allergen or a likely allergen. Clear? So let us understand above criteria through few cases. One case, first case, a 4-year male child, Master Ajay, presented to our emergency room with acute onset hives all over the body, followed immediately by fast breathing and collapsed. On examination, he was in altered sensorium with low systolic blood pressure and had wheezing also. So what is the diagnosis? Simple. So skin urticaria is there. Here there is involvement of this cardiovascular, there's circulatory as well as respiratory. So simple. This is a case of anaphylaxis as per criteria number 1, World Allergy Organization criteria. The presentation is very acute and rapidly progressing with skin involvement plus respiratory or circulatory. In this case, he had wheezing with low blood pressure with syncope. So in such cases, exposure to allergen history is not must. We are not wasting our time into the history. Later on, it may help, but at present in the casualty, directly go for management as per anaphylaxis protocol. Second case, a 5-year boy, Master Vilas, presented in a collapsed state to emergency room. He had consumed cake in party 30 minutes before the episode. His blood pressure was low, but he had no skin involvement, no urticaria, no angioedema, or his chest examination was also normal, and he didn't have even GI symptoms. But on history, parents told that the child had urticarial rashes after consuming egg at the age of 18 months. And he was diagnosed to have egg allergy in the past. And this time the cake contained egg, which he was not aware of. And so in this case, there is a likely or the highly known allergen is there. And the child presented to us with only single symptom, that is hypotension. And you still label the child to have anaphylaxis as per the criteria number 2 of WA class criteria. Clear? So now coming to the, as I'm saying, likely allergens, probable allergens, known allergens. What are the causative agents which are responsible for anaphylaxis? The prevalence of various causes are age dependent and vary in different geographical regions. So when it comes to infant, children, adolescents, and young adults, food is considered to be the most common trigger for anaphylaxis. And among the food allergens, the most common are milk, egg, peanut, tree nut, wheat, soy, fish, and shellfish. And to extend the list, we have lentils also, we have chickpeas also, which can cause allergy. Just 20. And when it comes to adults, most common triggers are drugs and insect sting. When, as a pediatrician, we must understand even after vaccination also patient can land up into anaphylaxis, and this anaphylaxis is because of the potential allergen which are present as additives in the adjuncts in the vaccine. Now coming to the mechanism of anaphylaxis. Now the main orchestra is at the level of mast cells. So whenever mast cell is degranulated, histamine and other mediators are released, and they are responsible for all the cascade of symptoms and signs. So how this mast cell gets degranulated? So there are high affinity receptors and low affinity receptors for IgE. And then the antigen, the IgE is bound to those receptors, and on re-exposure, when allergen comes, they cross links to antibodies, and thus the mast cell becomes active and degranulates. So this degranulation can be triggered by IgE, that is IgE mediated, which is the classical Ig mediated allergy, what we call it as. But we have non-Ig mediated also, where in non-Ig mediated we have immunologic and non-immunologic. So in immunologic, mainly instead of IgG is responsible, which are against the Ig antibodies or against the high affinity Ig receptors. So IgG are formed, autoimmune type of condition. Then we have complement system activation that also can lead to anaphylaxis, contact and coagulation system disorders, and in non-immunologic, we have direct activation of mast cells. And then there is a class where there is idiopathic. There is no, the pathophysiology is not yet understood, but those are labeled as idiopathic. So among the Ig mediated food allergens, mostly medications, among those, the penicillin group, the beta lactam groups, certain NSAIDs, the biologics, they are Ig mediated. Latex is very common. Aero allergens, insect sting, venom allergen, they are responsible Ig mediated. So radio contrast media can cause Ig mediated also, and they can cause even non-Ig pathway also they can follow. So in the immunologic IgG mediated complement system, most common agent is the radio contrast media. Imagine a patient in the CT room, all of a sudden collapse after giving contrast media. NSAIDs, most of the NSAIDs, they are non-Ig, they follow the path of non-Ig mediation. Then dextrans and certain biologics. Then non-immunologic, that is the direct activation of mast cells, alcohol, physical stress, they are, and the medications like opioids, they follow non-immunologic route. Then idiopathic, no apparent trigger is found, previously unrecognized allergen, mastocytosis or baseline mastocytosis or clonal mast cell disorders, they can present to us with recurrent anaphylaxis. So Ig mediated, there are different effector cells. When it is Ig mediated, the effector cells are mast cells and basophils, because they have that high receptor antibodies, receptors for Ig antibodies. Non-Ig mediated activation pathways are mediated by IgG, complement, bradykinin, leukotrienes, prostaglandin. And effector cells in such pathways, they are neutrophils, endothelial cells, smooth muscles, mast cells, basophils, even eosinophils are also. So this is the pathway. Here is the mast cells. We have high affinity receptors, low affinity receptors. We have complement receptors. So in case of non-Ig, we have immune complex. The immune complex triggers the complement cascade, and then it leads to degranulation. And the classic pathway is triggered by the allergen through the Ig receptors. We have preformed mediators like histamine, proteases, proteoglycan, TNF alpha, and then newly formed like leukotrienes, prostaglandins, they are released, and bradykinin. All this leads to skin and the various signs and symptoms. So Ig mediated, we mentioned what are the things involved, and immunologic also we discussed in that chart. Now idiopathic also we discussed. Now there are certain factors which increases the severity. So now, as Dr. Dipti mentioned, some patients get anaphylaxis, severe reaction, some get mild reaction, some may not get, just get limited to the urticaria, skin involvement only. So what differs? It's the certain cofactors, what we can say. So there are certain endogenous factors, and then there are certain exogenous factors. So endogenous, we have gender, age difference, cardiovascular disease, underlying cardiovascular disease, a patient on medications like beta blockers, then underlying mast cell disorders, mastocytosis, then underlying atopic diseases, uncontrolled urticaria, and then some ongoing infection going on. And exogenous, if a child is exposed to allergen and certain cofactors like physical activity, sleep deprivation, stress, and certain co-medications like alcohol and NSAIDs, psychological burden, all these can increase the severity of allergic response. So concomitant diseases, as I mentioned, allergic rhinitis and eczema, atopic condition, certain psychiatric illnesses, mastocytosis, cardiovascular disease, asthma and respiratory. So in them, now if you understand asthma patients, if they have food allergy, the chances of anaphylaxis is more. So always in a patient of asthma, always try to look for food allergy. So cofactors amplifying anaphylaxis: exercise, acute infection, emotional stress, disruption of routine travel in females, menstrual cycle, and all these things, menstruation, all these are stress factors. then alcohol, beta blockers, AC inhibitors, NSAIDs. These are certain drugs which can amplify anaphylaxis. Now, coming to the classification of severity, as I mentioned, some may have mild and some may have severe reactions. This is the simplest classification, which was published in 2001. Brown et al. This severity classification is still followed. Accordingly, we have the mild reactions means only skin and subcutaneous tissues are involved. Generalized erythema, urticaria, periorbital edema, or angioedema. Then we have moderate, where other systems are involved, respiratory, cardiovascular, or GI involvement in the form of, we discussed this symptoms. And then severe, if hypotension is there or neurological compromise, neurologically the patient is compromised, or cyanosis is there, hypoxia is there, then it is considered to be severe. But if we come to the latest 2021 Debrin system severity classification, and this is just the pocket guide, and you can see this is for all severe reaction, not only anaphylaxis, any allergic disorders. This can be used as for severity assessment. So there is a grading system application, and it is independent of whether reaction fulfill the anaphylaxis diagnostic criteria. So from the bottom, if we see bulk of the cases, mild allergic reaction, you can call it as when only skin, GI, or mucosal edema. So even if the patient is having GI symptoms like 1 to 2 episodes of emesis or diarrhea, or skin involvement in the form of localized urticaria, not extensive, erythema, and facial swelling, rhinorrhea, so you call them as mild. 2 or more mild, any moderate, when you call it as grade 2, then if their skin is mildly involved, and moderately means if there is generalized urticaria. GI mild, you call it as 1 to 2 episodes of diarrhea. Moderate, you call it more than 3 episodes of vomiting or diarrhea. And mucosal angioedema moderate, if there is oropharyngeal swelling, you call it as moderate. So 2 or more mild symptoms. So if skin, GI also involved, and skin is all involved, then you label them as grade 2. And grade 1 means either of these, either skin or GI or angioedema. And if there is only one system involved, but the symptoms are moderate, then also you call it as grade 2. Grade 3 is any mild. So in cardiovascular, neurologic, or respiratory symptoms. Now you can see these systems were not discussed in this grade 1 and grade 2. But here, if these systems are involved, but the symptoms of these systems are mild, and any one system, then you call it as grade 3. Like respiratory, if there is chest tightness, new onset cough, wheezing without increased work of breathing, then you call it as mild respiratory involvement. Mild neurological involvement means confusion, drowsy, irritability in infants, then you consider it mild. Cardiovascular, weak, dizzy, palpitation, tachycardia. So these are mild symptoms. But when these are called as moderate, when there is hypotension, syncope, mottling is present in infants, then it is moderate cardiovascular involvement. GCS of 13 to 14 and infants lethargic are considered to be moderate. And respiratory, there is new onset persistent cough, hypoxemia, increased work of breathing, and stridor with or without increased work of breathing. And grade 4 will be severe mucosal or angioedema. Severe oropharyngeal swelling is there, involvement of palate, tongue, uvula. Then you label them as grade 4. Grade 5 is any severe of these systems. So anaphylactic shock, cardiac arrest, hypotension, Glasgow Coma Scale, GCS of less than 13, infants hypotonia, respiratory failure, stridor with increased work of breathing, bronchospasm with minimal no air. So you consider as grade 5. So this is difficult to remember. Always this chart has to be there to grade as per this Debrin system. So I covered the pathophysiology, the severity classification, and the pathophysiology. Now coming to the diagnosis, serum tryptase, I would like to have 2 slides on the serum tryptase level for diagnosis, because again the pathophysiology, it depends on the pathophysiology. Now whenever there is an episode of anaphylaxis, suddenly within 30 minutes tryptase level go high. Histamine goes high before that, but within 1 or 2 hours histamine comes down. So always remember, measuring tryptase level must not delay initial resuscitation. So always we should not be in a hurry to collect sample to prove that this is a case of anaphylaxis. So they are useful in the follow-up of suspected anaphylaxis, but not in the initial recognition and treatment. Remember, for the initial recognition and treatment, we have those diagnostic clinical criteria. Now, coming to back to serum tryptase, we have these levels, and you can see the peak is between 0.5 to 1.5 hours, and we expect that we will be stabilizing the patient in the first 30 minutes to 1 hour max. So once the patient is stabilized, you collect this sample. Ideally, it should be collected at 30 minutes, then 1 hour, and then 24 hours. But only if single sample has to be sent, it should be between 1 to 2 hours after stabilizing the patient. And a baseline after 24 hours of the episode of anaphylaxis, a baseline tryptase should be measured. So how it is important when you will call it as increased serum tryptase level. So this was the formula which was given 1.2 into baseline tryptase. That is 20% more than the baseline plus 2 microgram per liter. So if that is there, then this is a clear-cut case of anaphylaxis. Retrogradely, next after 24 hours, we'll confirm our clinical diagnosis of anaphylaxis. But this formula was validated only in perioperative anaphylaxis. So anaphylaxis which arise on the operation table because of the drugs used for anesthesia. And so in for this, the sensitivity was 98% and specificity of 44% only. And this variability limits the rule. So this is not being used nowadays. Now, what has come out with is the alternative threshold, which have been proposed based on the index of suspicion. That means whether clinically you're, as per the criteria, if you have high suspicion of clinical suspicion of anaphylaxis, then anything above 1.374 times the baseline has got high sensitivity. High sensitivity means what? You can easily rule out. So below this, even if your clinical suspicion is high, if serum tryptase is less than 1.374 times less the baseline, if it is less than this, you can easily or confidently rule out it is anaphylaxis. But if the clinical suspicion is low, the value considered as high, 1.868. So this gives high specificity, that is ruling in. So anything above 1.868, even if you thought clinically this was not anaphylaxis, but still it is anaphylaxis if the values are high as compared to the baseline. Now you can see the specificity and the sensitivity levels around 97.5. But it depends on the clinical. But when you remove this clinical suspicion thing, a ratio of 1.685 gives a good sensitivity and specificity of around 94.4%. So it has become simple, and no need to remember this NIAID has come out with this calculator. So this calculator, you put the baseline tryptase. The baseline tryptase means after 24 hours, whatever value we get, you put the value over here, and the acute tryptase, which you took the sample at after 1 hour of the episode, you will. And then in this column, clinical suspicion, likely, less likely, or possible, you select whichever. And then you click on the analyze my data. So you will get this type of graph. So this is the acute tryptase measurement, and this is the baseline. Accordingly, a graph has come. This is the line of identity, and this is above the prediction threshold. So if it is likely, so this line will be closer to this. That is because above 1.3, your clinical is high, and if the clinical suspicion is low, if you click the less likely, this graph will be above this line what is seen over here. And if it is possible, it will be in between. So 1.3, 1.6, and 1.8. Accordingly, the clinical suspicion possibility. You get the patient's value over here. So looking at this graph, you can say that the change in total serum tryptase is consistent with the clinical diagnosis of anaphylaxis. So this is the website name where you can have this formula handy. And coming to the last part, biphasic reactions. So biphasic anaphylaxis reaction have been reported to develop in up to 20% of reactions. So that means initial symptoms are there, and generally we say after oral consumption of any drug or any food allergen, the symptoms will come after 20 minutes to within 2 hours you can get anaphylaxis episode. But if there is IV introduction of drug, within 10 minutes you can get these symptoms, and they get stabilized. But after 1 to 8 hours, they can have the second phase of reaction, second phase of symptoms. So why this is important? Because we, after stabilizing the patient, we should not immediately discharge. We should keep them there. So the late phase reactions are there, which comes to cause the biphasic reaction, but it is not always. It is still not clear. In some patient, it may be there. What has been observed is biphasic reactions are more. The chances of biphasic reaction are more if the initial symptoms, so the first reaction, is severe, or a patient who has history of recurrent anaphylaxis. In them, the chances of having biphasic reactions are more. So it makes around 20% of total anaphylaxis cases which comes to us with biphasic reactions. Thank you.
Thank you, Dr. Vikram Patra, for that elaborative talk. Almost all our doubts are clear. So it was really, really wonderful. The graphs were good. Everything was perfect. So I would not take any questions. We would take it in the end. So please, if possible, wait so that
Yeah,
if there
sure.
are any questions in the chat box, we can take them. So thank you for that excellent talk, Dr. Vikram.
Thank you very
So
much.
now we have another stalwart amongst us, none other than Dr. Narayan Prasad Modi himself, all the way from Odisha. And he's here to speak on the recognition of anaphylaxis in different age groups, that is pediatrics, adult, and elderly. And I feel it is a very, very important topic because most of the time in elderly, anaphylaxis goes undetected. Somebody calls it heart attack, somebody calls it stroke, somebody calls it just low sugar, panic attack, and they are just thrown away. In kids, it's very difficult because they don't speak, they don't tell. So I think it's a very relevant topic given by Dr. Neeraj Gupta to you, and I think you can do the honors to the topic. So a quick CV again. I'll be quick because if I go on in detailed CV of Dr. Narayan Modi, it will take half an hour. So he's a professor and HOD of PG Department of Pediatrics at MKCG Hospital, Brahmapur, that is Odisha. He has 20 years of teaching experience. He is EB member of IAP National Respiratory Chapter and his state chapter of allergy and clinical immunology. He is General Secretary of IAP NRC 2025-26, that is the National Respiratory Chapter. He has also been a trainer in various national modules like asthma training modules, allergic CADE modules, RTI jams, and he's joint national convener for ATM Revision Committee of 2021. He's national coordinator for Advanced Asthma Course 2022 to 24, and he's faculty for AASC, that is the Asthma and Allergy course. He's speaker in various national and state level allergy, asthma, and respiratory conferences. He has authored n number of books and chapters, and he has in his 7 international and 5 national publications. So his interest is pediatric pulmonology, allergy, asthma, and dermatology. A very warm welcome to you, Dr. Narayan Modi. Please go ahead with your topic. The stage is yours.
Thank you, Dr. Deepti, for all the kind words and a grateful gesture from the land of Lord Jagannath, from myself to PI chapter and Dr. Neeraj Gupta to have given me this forum and this important topic. So I hope my slides are visible.
Yeah, can you put it on the presentation mode? Full screen, please.
Is it full screen
Perfect.
now?
Yes, yes. Go ahead.
Thank you.
Yes.
So with reverence to all these stalwarts, noble persons who have given me the knowledge of allergy and immunology. Now, this very, very important topic, and succeeding Dr. Vikram Patra's talk, a huge load off my shoulder for this topic, recognition of anaphylaxis in children, adults, elderly, and different timelines of life. So why this topic? Because it's a very, very important word in the lexicon of our Mother Earth, then why we choose this topic? Because recognition is the most important aspect of management of anaphylaxis. Because treatment, we know one treatment, immediate treatment, fast treatment. But to recognize it early and with all credibility and precision, that is most important. And why? Because it differs in presentation, evolution, and in severity in different age groups. Most suffering from anaphylaxis, they succumb by the time they reach the hospital or healthcare facility. So, detecting early and appropriately, that is most important. And we know 50% of anaphylaxis, they are happening in the home, and another 50% in school or hospital healthcare facility. So this recognition part should go to the community level besides being there with the healthcare providers. We must empower all this section of society. Then only we'll be able to do a good justice to this clinical entity. And of course, maximum research is happening only in this area of recognition, because this is a very acute, sudden onset, fatal clinical entity. Not lot many research are happening or can be done. So recognition is very, very important, and it is most critical to bring down morbidity and mortality. And anaphylaxis, as has already been spoken, that this is a very under recognized clinical entity. It is under presented, under recognized, under reported, under studied, under preparedness is there at all level of the society, including the healthcare facility. It is under treated even, and of course under followed up. So it's an under thing. And that is why this week PI has taken up this wonderful initiative led by Dr. Neeraj Gupta. So the definition has already been enumerated, broadly spoken by Dr. Bikram Patra. So now, besides being this focus on airway, breathing, and circulation problems, now this little twist has come up in recognition of allergy, that we should not always depend on skin features. And without any circulatory problem being evident or shock being there, we can still suspect and diagnose anaphylaxis. That is the message from World Allergy Organization 2020. In severe allergic reactions, we recognize these two important entities. One is acute severe asthma, clearly defined, much studied, decreasing in incidence, mortality is reducing, wonderful drugs are there, they take care of the issue. But anaphylaxis, it is still not much understood, not much studied because of its inherent deficiency. And of course, the incidences are increasing, but mortality remaining the same, because awareness is not at that level, intervention is not at that level, preparedness is not at that level. This different forms of anaphylaxis has already been spoken by Dr. Bikram elaborately, so I will not delve into much into this. Now coming to the recognition part, we must fear anaphylaxis as far as the recognition part is concerned. So it should be fast. We must be at it. The recognition part should be fast. And we should always be very keen to recognize the early symptoms. Besides being first, early features of anaphylaxis should be, because it doesn't give us time to be managed. So that is why early recognition is important, and the recognition should be accurate. And besides recognizing, the process of recognition of anaphylaxis, we should be always reassuring to the caregivers and the patients also. So these four should go hand in hand. And how the recognition will come? To suspect, and suspect across all ages. Why we should suspect? Because of its unpredictability. We already had discussed that it differs in onset, presentation, the trigger, the factors in different age groups and in different geographical area. So because of its unpredictability, high fatality and increasing incidence across all ages, suspicion is the key in anaphylaxis. It is already discussed that age-related factors are there. Infants, they cannot say anything. We have to be very, very keen through our eyes and mind to suspect and pick up anaphylaxis. Adolescents, they are always risk-taking. They will not divulge what they have taken. They will not take their EpiPen injection. They will forget. They will not listen. They will not obey any advice. So they will always be at increased risk of developing anaphylaxis. Labor and delivery, they will be, we all know that this period is a very, very sensitive period and all sorts of allergic reactions and adversities will happen in this age group because of different drugs, the different biology. So they are at risk. And elderly, they are very poor perceivers, lot many comorbidities, polypharmacy is there in this age group, and lot of things, they go unrecognized, they are subtle, and they are atypical. So both in very, very early age and in elderly age group, they are really critical as far as anaphylaxis is concerned to be recognized. So how they present anaphylaxis? They differ in severity. From mild to fatal, we have already discussed different classifications. The less severe early findings may progress to life-threatening over a very, very short period of time. That is very critical to know. Initial sign symptoms, they do not necessarily correlate with severity, progression, duration of response. So what the child or the patient presents with initially is not at all correlating properly to the outcome or the severity ultimately. Generally, the faster the symptom development, the more severe the reaction. That is very critical. We must remember this. Fastness of evolution of symptom. And acute, unexpected, dramatic onset, they may vary in severity. Another thing we must not forget that anaphylactic episodes, they may resolve spontaneously. And we'll come to this aspect of anaphylaxis later. How this is so important to be remembered, that anaphylaxis can resolve spontaneously and why it is. Clinically, we must depend on 4 of our spatial senses, that is speech. We must ask, hey, how are you feeling? What is happening? What troubles you? What is the problem? And the patient may complain chest tightness, sense of doom. The child or the patient will tell, no, I think I will die. Dysphagia. And call for help should be there from the caregiver aspect, healthcare provider aspect, and as well as from the patient aspect. Then what we must observe, we should have a closed loop. Paleness or a flushed skin, either way it is important. Sweating, postural loss, fast breathing, and touching. To touch, the skin should be calm if it is pale, warm if it is flushed. And what we must hear, hoarseness, change in voice, then stridor, wheeze, cough, and they all should be acute in onset without any pre-setting, sudden, dramatic. So these all should make our brain tick to think of anaphylaxis. These 2 special senses, they are not very useful in detection of anaphylaxis, that is smell and taste. What are the subtle signs? Before we go on to different age group, we must remember the pooled subtle signs. What are all they? We must not forget at any point. Flush, skin, and hives. And they are one of the earliest features of anaphylaxis. Pain abdomen, swelling of face, lips, eyes, and inside also. organs, pharynx, larynx, trachea, GI tract, sudden onset of itching of abnormal areas, sole, then palm, then scalp. These are all atypical areas and sudden onset of itch. Out of nowhere, the child or the patient would itch. Besides itching in eyes, nose, so they all should make us think. Nausea, vomiting, sudden feeling of weakness. So these all are subtle signs. But most importantly, we must not forget these signs in infancy. They are very, very subtle. They go unrecognized. And we must be at it to pick up. That is the key, drooling of saliva. Suddenly, out of nowhere, drowsiness, irritability, a sudden appearance of grunt or nasal flaring, and clinging to the caregiver. The child would just go on and latching to the mother, just picking her sari or her dress, clinging to the caregiver. These are very, very soft and subtle. We must be at our best to observe and pick up these things. And what are the early signs? These are all subtle. Then what are the early features of presentation of anaphylaxis? Acute rhinorrhea without any setting. Suddenly, a sudden appearance of runny nose. Skin reaction, flushed and pale skin, hypotension. They are early signs in adults and elderly. And mind you, dear friends, hypotension is a late feature in childhood, early childhood, less than 5. Hypotension is the late feature. But in adults and elderly, hypotension is early feature. Constriction of airways, swollenness of all the external skin and internal organs, causing wheezing and trouble breathing, stridor, tightness, weak and rapid pulse, nausea, vomiting and diarrhea, and repeated, refractory, dizziness or fainting. So these are early feature of CNS involvement of anaphylaxis. So these all should be in our mind when we are suspecting or trying to pick up anaphylaxis out of nowhere. When should a child should be sent to emergency room? Immediately, a rash such as hives plus any of the following with nausea, vomiting, swelling of eyes, cough, shortness of breath, swelling of lips and tongue, a feeling that your throat is closing. So skin feature plus any one of the following, immediately that child or the patient should be attended in ER. This wonderful landmark 3 boxes of picking up anaphylaxis, diagnosing clinically. These boxes are passed. These have already been discussed. We'll not go into detail of that. Now we are following this World Allergy Organization 2020. So 2 boxes, any one of the 2. So first is the skin features with any one, airway, circulation, and GI. And in GI, severe GI symptoms without any known food allergen. That is the new thing which has entered into this clinical recognition of anaphylaxis. Like you can say latex. So you can say aeroallergen. You can say a bee sting or insect bite. So these things and sudden severe GI symptoms, repeated diarrhea, severe vomiting, severe crampy refractory abdominal pain. So these things will make us think, oh, this may be anaphylaxis, even if there is no known or suspected food trigger. So this will make us think of a case as anaphylaxis. Or these 3, a known or highly probable allergen with any one of these, hypotension or airway problem or laryngeal involvement. So any one of the 3 with assisted by a known or highly probable allergen. So this has been simplified in 2020 by WOW for diagnosis of anaphylaxis. What are the caveats? We should not depend on skin features to pick up anaphylaxis. Skin or mucosal changes can be subtle or absent in 20% of anaphylactic reactions. And there can also be GI symptoms. And severe GI symptoms without known food trigger is a very, very new thing that has entered into clinical recognition of anaphylaxis. So now different age group in less than 2. We have discussed in these subtle soft features and early features, increased fussiness or irritability, inconsolable crying, unusual quietness. We play full half an hour before, but suddenly is quiet, silent, sleepy, drowsy, sudden onset of drooling, frequent regurgitation or vomiting, changes in feeding behavior, not taking to the mother's breast, not feeding, suddenly there is a change. So that should make us think of, no, something is wrong. Something very rapidly is going to happen. Increase rubbing or scratching at the mouth, ears, or skin. So these are all very, very soft because these children, they cannot say anything. We should be at our observant best to pick up. And what are the early features of circulatory issue? Paleness of skin, lethargy, unconsciousness, because we know that hypotension is a late feature in underwear. And infants, sudden onset, I have already discussed sudden onset of grunt, nasal flaring, clinging to the caregiver. Please mark, please observe what is there happening to the child. In preschools, respiratory problems enters. Sudden onset of laryngeal involvement, stridor, expiratory bronchospasm, then difficulty deglutition, hoarseness, change in quality and intensity of voice. So sudden onset of all these in this age group, besides going into those defined clinical criteria from WOW, should make us think of anaphylaxis. In 6 to 12, they should be more vocal. They will be able to tell something, their problem. So what we should observe, what we should ask. They should complain of, sir, there is something happening in my throat. I am not able to talk. I am not able to swallow. I am not able to eat. And nothing is going inside, down. They will complain, no, I am not able to breathe. There is something happening. Wheeze, stridor. So they will complain. And besides, of course, there will be appearance of generalized urticaria with angioedema. So this is a very important issue in this age. So if some this thing happening in combination, we must think of anaphylaxis. 12 to 18, we have already talked a bit. They are in the age group of increased risk taking. And there, the cardiovascular system takes precedence over other organs, increased CVS features, dizziness, then appearance of fainting, sudden fainting, collapse, and extreme anxiety, sense of doom. Like they will say, no, sir, I feel like I will die now. I'm dying. Something is happening. My throat are closing. So they will speak in this tone. So these all should make us think of. So these are all in different age group, subgroups of childhood. They usually occur in less than 2 hours of exposure to allergen. Most commonly, they react to food, drug, latex, insect bites, and in many cases, they are all idiopathic. Now, coming to what is happening in adult age. Skin mucosal symptoms, they may go unrecognized, subtle, soft, or absent. I told CVS features takes precedence in beyond 12, 13, beyond adolescence. So hypotension, dizziness, syncope, chest pain, increased heart rate. So they enter into the features of anaphylaxis. Respiratory signs, symptom, dyspnea, wheezing, sense of throat tightness, GI symptoms, nausea, vomiting, abdominal pain, and diarrhea. Then again, extreme anxiety, sense of doom. So these are features beyond adolescence. They will complain of these things. These are features of adults. Triggers will be less amongst food, drugs, and insect sting. They take precedence over food allergens. They are more common in children. Insect sting is they majorly present with CVS features and less of skin features. So this thing, because we know that insects sting and drugs, they come into prominence ahead of food allergens in adults and elderly. So there we get more of CVS features and very, very less skin features. In elderly, they are like at same level with infancy, because in infancy they will not able to tell, and majorly the signs and symptoms features are soft, subtle. In elderly, atypical features, chest pain, confusion, what is happening, where they are, what is the time, they will not know. So that should make us think of, oh, something is happening. Fainting, hypotension, dizziness, loss of consciousness, CNS features, CVS features, they come into play in anaphylaxis. Arrhythmias, Connish syndrome. What is that? Acute allergic coronary syndrome, Connish syndrome. So, irregular heart, irregular pulse, abnormal pulse, suddenly happening should make us think of anaphylaxis in elderly. Skin features comes down in incidence and prominence. There cyanosis, hypoxemia, decreased SAT, incontinence, the end organ dysfunction, incontinence of urine or feces. So these things should make us think of anaphylaxis in this extreme anxiety, sense of doom. Again, a common feature I have already told, beyond adolescence, through adults and elderly, these things should be there uniform. Again, drugs, insect sting, they are more important as regards head to food allergens. What are the most important things contributing to or interact or interplay with anaphylactic reactions in elderly? Because there is already immunosenescence. It is now coming down in tolerance and in potency. Subtle features are more like infancy. There are a lot of comorbidities, lot of drugs already being taken by the elderly public. So there the reactions will happen, because we have already discussed a lot many cofactors in that drugs are there. So anaphylactic reaction should be suspected majorly to recognize and diagnose clinically. Biomarkers, tryptase has already been told, then serum specific IG, they are not important as regards the management of anaphylaxis. They are just for academic purpose. So oral food challenge, they are there to help us to diagnose, recognize anaphylaxis retrospectively, specifically when we have already suspected in an atypical presentation and have already treated. Because anaphylaxis, we don't need a confirmation of diagnosis. Even a suspicion will make us treat the patient to save the life. Clinical features we have already known. So these are the different in contribution, skin, they are maximum, they are most common, then coming down CVS, respiratory system, and CNS, mostly secondary features. So this is from ACI from 2013. There is a rule of 20, idiopathic 20%, recurrent 20%, cofactors 20%, absence of derma symptoms 20%, GI symptoms 20%. So I have made this as a rule of 20 in anaphylaxis. Grades we have already discussed, mild, moderate, severe. So we will not discuss risk factors. So these are the major risk factors. And sudden onset of any acute reaction, and these risk factors we have probed, we have gathered from history, then we should think of anaphylaxis. Cofactors has already been discussed, majorly fever, infection, exercise, drugs, and stress, both physical and mental, and of course, alcohol. So these are the cofactors. They just they're the trigger. They just sets an anaphylaxis off. Operation anaphylaxis. So what is there? The accuracy of recognition. Then the speed with which we recognize, what will happen? Then a very, very fatal Muritke-like terror camp like anaphylaxis can be precisely targeted and destroyed. So we have to be accurate, and accuracy should be with a lot of speed. Then only we'll be able to conquer anaphylaxis and save a life. So these are different clinical scenario. Now, after all this, like a 1.5-year-old boy had cow's milk half an hour back. Suddenly developed articular lashes, continuous loose watery stool. So this will come like in 2020, wow, first criteria. So there is a milk intake half hour back, then skin features with GI features. So this will immediately, we should be thinking of anaphylaxis, and as the time of thinking, we should be preparing and we should be able to give injectable adrenaline IM immediate. Then only this child will be saved. Another child of 7 with bee sting came to emergency department. He has facial edema, wheezing, vital signs stable. So angioedema is there and airway pictures are there, and a setting is there with bee sting, insect bite. So immediately recognition of anaphylaxis, and we should go on to treat immediate. Another 13-year-old boy, history of atopy, suddenly lost posture and fell down after 15 minutes of exercise. Now this is a very suspicion is the key here. Now there is no known allergen, no exposure, but there is only a trigger of physical exercise, and there is sudden postural loss. So is it food dependent exercise induced anaphylaxis? So is it non-IG mediated anaphylaxis because trigger is exercise? So these are all things are there academically. We should think, but we should not wait for the treatment, because 13-year adolescent, high risk taking behavior, the child must have taken something, must have been hiding something. So this should wait. These all can wait, and the final confirmation of anaphylaxis can wait. Injectable adrenaline should not wait in this child, because we all know that injectable adrenaline given IM in acute severe reaction, there will not, it is not a contraindication. We can always give. Another 15-year-old girl undergoes prick skin test, suddenly fell on the floor, postural loss, heart rate is 60 per minute. So what is happening there? 15-year-old adolescent going through prick skin test, postural loss. Is it anaphylaxis? Is it syncope only? See, heart rate is 60. So there is bradycardia. So in anaphylaxis, we have tachycardia. So probably this child, this 15-year-old girl is having a syncope. But monitoring should be there, because we don't know. This may go on to anaphylaxis. We don't know as yet. So we have to wait, we have to monitor. Differential diagnosis. So these many common differential diagnoses are there. For anaphylaxis, vasovagal attacks, I have just now discussed, panic attacks, upper airway edema, vocal cord dysfunction, hereditary angioedema, systemic mastocytosis, other causes of acute respiratory severe symptoms, even acute coronary syndrome, myocardial ischemia in adults and elderly. We may miss anaphylaxis thinking of all these things. Carcinoids, bipomas, and thyroid crisis. So these are the common differential diagnoses for anaphylaxis. Finally, dear friends, recognition is the key. Many features can go unnoticed. Many are soft, subtle in early age and late age, elderly, more common than we think of. This anaphylaxis incidence and prevalence, they all are rising because of our change of lifestyle, food habit, and all those risk-taking behaviors. Fast and early detection is the key. Infants, elderly, many are subtle and atypical features. Our eyes should be very, very keen. to pick up all those. In infants, subtle features are there, non-specific, constitutional, and skin and GI features. They are common in children, skin and respiratory features. Adults and elderly, they are more of cardiovascular problems and sense of doom, anxiety, something critical is happening. So they will complain of all this. But we should let go the ego in picking up. I had already discussed that anaphylaxis can be self-limiting. So suppose a child comes and the parents say, sir, these things happened 1 year back. So nothing, we didn't take him to the hospital and nothing untoward happened. So the parents are there with their ego, and we physician, we may be in our ego, okay, this will not happen, sense of denial, no, it cannot happen, it can't be anaphylaxis. So these things should not come in the way of our recognition of anaphylaxis. Even if one anaphylactic episode went uneventful in the past, should not prevent us from treating the present anaphylactic episode. We have to treat it urgently, immediately, even if the previous one was uneventful. So we should forego our ego to pick up and to treat anaphylaxis. Thank you so much.
Thank you, Dr. Narayan Modi, sir, for that wonderful and elaborate description on how to pick up subtle signs and how to let our big egos go away. So that was wonderful. I think with that detailed description, I doubt that there would be any doubts. So thank you for making things so clear for all of us. Thank you. So let's move on, friends. I hereupon call our esteemed Professor Suresh Gupta, sir, to speak on emergency management of anaphylaxis, what every doctor must know. Dr. Suresh Gupta needs no introduction. He is a renowned senior consultant of pediatric emergency and critical department in Sir Gangaram Hospital, New Delhi. Sir has attended numerous conferences. He is a national faculty. He has lots of chapters under his name. So I welcome you, Dr. Suresh Gupta, sir. Please go ahead. Thank you.
Thank you, Dr. Dipte.
Chale?
Just let me share the screen.
Sure.
Is my screen visible to everyone?
Yes, sir. Your screen is visible and it is full screen. Yes, please go ahead.
Thank you. So after this brief introduction, I'm really thankful to the organizer for giving me opportunity to share my views and my experience regarding ER management. As has been highlighted by previous speaker, and immediately before me, Dr. Modi was talking about diagnosis and early identification. So it's very clear that diagnosis is made clinically, you don't have to have any investigations. And allergy, particularly anaphylaxis, is very, very unpredictable, right? It can be very, very mild and resolve spontaneously on one hand, and on the other hand, it may be very life-threatening, involving cardiovascular and respiratory system. So when a child is developing anaphylaxis symptoms, at that time we are not sure how fast this is going to progress, how far it is going to go, and how it is going to respond to the treatment. So immediate initiation of treatment becomes very important to prevent morbidity and mortality. This has been highlighted that this anaphylaxis can have uniphasic presentation, only having symptom then resolve, or sometime biphasic, having a second phase, and sometimes the course can be very, very protracted. So I will not go into the clinical details because those have been discussed in great detail by the previous speakers. I will limit myself to ER management and what are the issues in that. Remember, these are the danger signs which suggest that this child may be progressing towards very severe condition. Any child having anaphylaxis with respiratory distress, any child having severe vomiting and abdominal pain, or any child having cardiovascular symptom in the form of hypotension, dysrhythmia, chest pain, or collapse. So these are signs of great severity. The ER management involves acute management, and there are some adjunctive therapies, and I will then talk about treatment of refractory symptoms in very brief. Acute management, the first and foremost is adrenaline or epinephrine. And remember, there is no absolute contraindication to epinephrine. Even pregnancy or newborn, even a person having cardiovascular disease, there is no contraindication for the use of adrenaline. Regarding airway, right, immediate intubation is required only if there is an impending airway obstruction from the angioedema. So airway is not a priority in most of the cases of anaphylaxis unless you are having a patient is having angioedema, and of course that will be very obvious with hoarseness of voice and stridor. Whenever we talk of stabilizing any sick child, we always say, okay, start this ABC, stabilize airway, breathing, circulation. But in management of anaphylaxis, D take the priority over A. So don't delay the drugs. And here I replace airway by the adrenaline because that is the priority, right? And airway comes later. So we should have a written emergency protocol for recognition and treatment of anaphylaxis, and we should rehearse it regularly if we want to manage it properly. And always try to remove exposure to the trigger if that is possible. Like somebody is on IV diagnostics or therapeutic agent, that should be stopped immediately. Acute management. So these few steps are to be done simultaneously and immediately and promptly. First, IM epinephrine. Second, place the patient in recumbent position, but only if it's tolerated. If the patient is having respiratory symptoms, they may not tolerate this posture, and then let them be in the posture of the comfort. Oxygen, try to give as much as oxygen by non-rebreathing mask, right? That can supply around 70 or 80% of oxygen. Simple oxygen with simple face mask is not sufficient under these life-threatening conditions. Ensure a IV line, and if the patient is having hypotension, you'll give saline bolus. And for bronchospasm, you can start salbutamol. So let me take each and every point now. So what are the indications of using epinephrine in a child with suspected anaphylaxis? Any child who fulfills criteria of anaphylaxis, this is the first line treatment. Even if the patient is not fulfilling all the criteria and you are having just suspicion that yes, it can be anaphylaxis. Even in those cases, one should not hesitate to use epinephrine because using IM epinephrine is very, very safe, but anaphylaxis can be life-threatening. How early and how frequently this epinephrine should be used? It should be used as soon as you suspect, yes, there may be anaphylaxis. You don't need any confirmation. A suspicion is sufficient in most of the cases. And then you can repeat every 5 to 10 minutes or more frequently, depending on response of the patient. Epinephrine, the strength which is to be used is 1 in 1000. And in India, the strength which is available in Adeline ampule is 1 in 1000. 1 in 1000 means 1 milligram in 1 ml. Right? Dose for adult 0.2 to 0.5 milligram. For a child, 0.01 milligram per kg or 0.01 ml per kg. Site, the best site is lateral thigh. If that is not available or cannot be used, deltoid is the alternate. But still lateral thigh remains the site of choice because this is one of the biggest muscle of the body, and we deliver a drug in this muscle, it gets absorbed much faster than other area. Route, always intramuscular. Never use subcutaneously because subcutaneous absorption is not reliable in such a life-threatening condition. Intramuscular route is still considered to be safer than IV route. I will come to that point. But let me tell you one more thing which we have to consider with change in society and human behavior. As we know that obesity is getting more and more prevalent, and morbid obesity is also increasing day by day, right? And this is becoming very common in children now also. So I just try to look how much subcutaneous fat thickness can be there on the thigh actually, right? Because the needle length is very important. And in this study, it shows that in obese person, the thickness, subcutaneous thickness over the muscle can be as high as 3.5 centimeter or even more. And most of the needle which we use in our practice may be just 2 or 2.5 centimeter. So needle length is very important, and more important if the patient is obese. If you use a very short length 2 centimeter needle or 1 inch needle in a very obese patient, though your intention is to deliver the drug intramuscularly and trying to give intramuscular, it may not reach intramuscular compartment and it may remain intra or subcutaneous only, though you think that you have delivered the drug intramuscular. So this fact also becomes important. Second thing, and now as we are promoting more and more aniline auto-injectors, and most of the auto-injectors, right, even adult ones, have a length of 2.5 or 2.3 centimeter only. And in these obese patients, it may not deliver the drug to the desired location where we want. And in pediatrics, the needle length is further shorter with auto-injectors. So this point becomes very, very crucial. Epinephrine, as we know, is underutilized, and often because of fear of side effects, the use is delayed. Often it may be given in an underdosing or inappropriate doses or inappropriate route. And one of the studies shows that only 30% patients who needed epinephrine actually received. So 60-70% patient didn't receive it. Right? Remember that up to 20 or 30% may need a second dose. Regarding epinephrine dosing, right? Suppose somebody has an auto-injector also in the emergency department, and you have a needle syringe and epinephrine ampule also. So which one will you choose? For infants, if it is not delaying, then delivering the exact dose in the form of 0.1 milligram per kg or 0.1 ml per kg of epinephrine is always preferable over auto-injector, because the lowest dose of auto-injector which is available is 0.1 milligram. So side effects become little large. But in older children, infants and children, and young adults less than 50 kg, right? You can use auto-injector 0.15 milligram and 0.3 milligram. But if the patient is overweight, obese, or above 50 kg, right? Then we think that giving a appropriate dose, 0.5 milligram, is very important in those cases. In those cases, because there is no auto-injector which has got 0.5 milligram. Only the dose which is available is 0.3 milligram auto-injector. In those cases, you can use 0.5 milligram from the ampoule, provided it is not delaying it. If it is delaying, then whatever is available, give it immediately. Regarding auto-injector, time is very important. When you activate the auto-injector, you must wait at least for 3 seconds after activation, right? Don't just inject and take out the auto-injector, because it may not deliver the drug unless you wait for 3 seconds or more. So this wait period is also important with auto-injector. So epinephrine, all of us will know. How does it act? It's a physiological antagonist, right? And it has got an alpha receptor effect, which causes increased vasoconstriction, increased peripheral vascular resistance, and increased blood pressure, decreased mucosal edema in the larynx. It has beta-1 receptor effect, causes chronotropy and inotropy, and beta-2 receptor effect, decreased mediated release from the mast cell and basophil, and increased bronchodilation and vasodilatation. Are there any adverse effects? Yes, some of the adverse effects are common but transient and not troublesome, which include anxiety, palpitation, pallor, fever, some tremor. They may have little effect, fear-like feeling or restlessness, dizziness, or headache. But uncommon one are cardiovascular, like ventricular arrhythmia, angina, myocardial infarction. They are very, very rare, and they typically occur when an overdose is given or an IV bolus is given. They are not observed with appropriate intramuscular doses. So assessing response to intramuscular epinephrine, most patients will respond to single dose of IM epinephrine, and the effect will be evident within 5 minutes. But a retrospective studies indicated that second dose may be needed in 10 to 30% of cases, particularly those who are having anaphylaxis due to drugs or foods. And the children who are presenting with flushing, diaphoresis, or dyspnea are more likely to need a second dose of epinephrine. So what are the situations where epinephrine may fail? Right? It is a very, very severe reaction. A single dose may fail. If the patient is arriving too late, it may fail. And of course, if you are giving inadequate doses or wrong route or expired drug, of course, it may fail, because epinephrine has a very short expiry, less than 6 months or 1 year. And because anaphylaxis is not that common, the drug may not be used, particularly in clinic setting or OPD setting, and drugs may get expired. And in some cases, beta blocker and ACE inhibitors, those are ACE inhibitors or beta blocker, the epinephrine may not sometime work. This last point I will like to take little in more detail, because there is often a myth that patients who are on beta blocker or ACE inhibitors, they do not respond to epinephrine adequately, right? This is a fact that these patients are more likely to anaphylaxis. However, in a retrospective study of 789 patients presenting to ER taking beta blocker, and it was found in them that they were no more likely to need epinephrine, more dose of epinephrine, or need additional dose of epinephrine than patients who are not taking beta blocker. So remember, the clinical impact of these beta blocker and ACE inhibitors is very, very small. That's why nowadays, even the patient who has experienced a anaphylaxis and suppose he's taking beta blocker or ACE inhibitors, the risk of stopping these drugs is more than the benefit of stopping. So generally, they are continued on these drugs. Are there any situations where epinephrine may be given by bolus? But when I say bolus, I really mean slow bolus, not a push, right? And this bolus, when it is needed, is given in those cases if there is a cardiovascular collapse or impending cardiovascular collapse that has not responded to intramuscular epinephrine and volume resuscitation, right? And even then, if epinephrine, if you don't have facility for infusion, then you give bolus. If infusion is available, you always start the infusion. Suppose the circumstances that you're not able to start the infusion. In those cases, you can give IV slow bolus, which is given over 5 to 10 minutes, not 1 to 10 minutes, right? And the dose which is used here is 50 to 100 microgram. It's not same as intramuscular dose, which is 100 microgram to 500 microgram. The dose over is much less in slow bolus. So when do you say it's a refractory anaphylaxis? Though there are no commonly agreed criteria or consensus when we should call it anaphylaxis, but most of the people believe that if anaphylaxis is present even after giving epinephrine and symptom-directed medical management in the form of IV fluid boluses, right? So they are considered to be, and those who are needing IV epinephrine infusion, they are considered to be refractory anaphylaxis. So what is the treatment line for anaphylaxis? You start with epinephrine infusion. The dose generally we give is 0.1 microgram and gradually built up to 1 microgram per kg per minute, right? And if they are not responding to that, even you can go up to 2 microgram per kg per minute. In severe cases, you can add on other vasopressors, particularly vasopressor like norepinephrine vasopressin. Glucagon may be useful in those patients who are on beta blocker or ACE inhibitors. And in non-responding cases, where so much of vasodilatation, methylene blue can be sometimes helpful, and rarely a ECMO may also be needed. Glucagon, right? this point I already emphasized that useful those were on beta blocker and refractory to epinephrine, because epinephrine has a direct inotropic and chronotropic effect, and it is not mediated through beta receptor. The dose in adult is 1 milligram. You can go up to 5 milligram if needed. In pediatrics, 20 to 30 microgram per kg. It is given slow IV bolus over 5 minutes. But remember that such a fast bolus of glucagon sometimes may induce a severe vomiting episode, and if the patient is unconscious, there are great chances of aspiration. So be careful about that when you're giving IV glucagon bolus. Put the patient in a lateral or side. Other adjunctive therapy, which doesn't control the anaphylaxis directly, but plays role somewhere in controlling other symptoms, like H1 antihistaminics and H2 antihistaminic. H1 antihistaminics like cetirizine, which can be given oral if patient is conscious, but it is only meant to control pruritic symptoms, skin symptoms. It will not affect our cardiovascular or respiratory or GIT symptoms. H2 blockers, particularly cimetidine or famotidine, which is used, can be given IV. But they are not the priority at all, and they never be used as first-line therapy, thinking that anaphylaxis is mild. I'll talk about glucocorticoid, where it is used, and monitoring is important in any sick patient. Role of corticosteroid, it has been shown not to be effective in acute treatment. Theoretically, it may prevent protected anaphylaxis, but the evidence is not very, very strong, right? And there is no conclusive evidence that it may prevent biphasic response. Previously, it was thought that giving glucocorticoid may prevent second phase of anaphylaxis, but it has been shown that it is of no benefit. So where we should use? Most of the experts agree that there is no need to routinely administer corticosteroids with response to intramuscular epinephrine and other measures, and being discharged from emergency room itself. But if the symptoms are very severe, requiring hospitalization, like refractory anaphylaxis, or any patient with asthma or bronchospasm, but that is persisting in spite of giving initial treatment of anaphylaxis, there you can use. If the bronchospasm is released after giving intramuscular epinephrine, there is no need to give steroid even in these cases. Next speaker will be talking about observation and need for admission, right? In brief, a patient is coming to emergency room. I will say that all patients who have got severe anaphylaxis should be admitted under a monitored unit, and particularly those who do not respond to intramuscular epinephrine, require more than one dose of this thing, they should be admitted to observation unit. And those who have significant delay in administering intramuscular epinephrine, they should also be admitted. But the patient who responded adequately to first dose of epinephrine, they can be discharged without steroid with the, from the emergency room directly, unless there are other risk factors. Discharge care, anaphylaxis emergency action plan should be given to the patient, and he should be given at least one epinephrine auto-injector if possible, printed information regarding anaphylaxis treatment, and advised to follow up with the allergist. And they are, this is the American Academy of Pediatrics Allergy and Anaphylaxis Emergency Plan. I think even IAP emergency, this allergy chapter should try to formulate such a action plan to be administered in the school setting or hospital setting. Follow-up care, patient with anaphylaxis should undergo follow-up to confirm the cause and receive education regarding prevention, right? Because a study has shown that 35% of patients who initially received treatment for anaphylaxis were later found not to have anaphylaxis, or the cause which was thought to be different. So proper evaluation is important after first episode. This is a mnemonic which has been designed for emergency room or a primary care physician. Safe, seek support means you are asking the patient to seek support regarding knowledge and allergy identification and avoidance, follow-up for specialty care, and how to use epinephrine for emergency. So SAFE is a mnemonic which is very useful for primary care pediatrician, not only primary care pediatrician, even for the allergist. Risk of recurrence, I can skip this slide because another speaker will talk about risk of recurrence. And in the last, I will ask you to take this A and D, right? A, 7 A's, which I always say, always administer adrenaline anterolateral thigh intramuscular in adequate dose. Agile means as fast as possible for anaphylaxis. And D, don't delay diagnosis. If doubt, better to treat. Remember, drugs take precedence over ABC. D, don't hesitate to give adrenaline even if you're not sure. And don't discharge the patient from ER if the patient is very sick. Thank you so much. I'll finish here.
Thank you so much, Professor Suresh Gupta. That was an excellent deliberation. Thank you for bringing up the size of the needle for obese patients, which we are facing this problem nowadays. And thank you for your A's and D's. It was wonderful listening to you. Thank you so much.
Most welcome. Thank you. Thank you.
Thank you. So now, as we all know, we are running short of time, but we have a very important and esteemed speaker, all the way from the United Kingdom, Dr. Mala Raman. She is a welcome, Dr. Mala. She is a consultant pediatrician at University Hospitals, Plymouth, and she has done her MBBS from Riva University, and she has also done MSc allergy, and we are so very fortunate to have her today. She will be speaking on a very important topic: post-anaphylaxis observation, discharge planning, and education. Because we all know we have recognized, we have treated, done everything, but then what? We are all very apprehensive what to do next. So we have a very esteemed speaker with us today, Dr. Mala Raman. Ma'am, the stage is yours. Professor Gupta, can you please stop sharing your screen?
Okay. I think it has stopped share.
No, if you can just press that, click on stop sharing.
Okay, I'll just.
Yes. You have done
Thank
it.
you so much, Dr. Deepti, for giving this introduction. And I would like to thank Dr. Neeraj Gupta for giving me this opportunity to educate myself. Such excellent speakers, Dr. Patra, Dr. Modi, Dr. Suresh Gupta, and yourself in between. You gave all these pearls of wisdom, which was brilliant. So my talk, I have actually deleted lots of slides because everything has been said. But I am, if I can just share my slides.
Sure.
mindful of the fact that we are quite late. I think everyone must be very tired.
No, you take your time. We are so privileged to have you. There is that green square at the bottom of the screen with an arrow.
Yeah,
Green square.
yeah, sure. I have pressed that, but I have it on my desktop.
I think it should work from the desktop as well. Have you pressed that green block, the one with share?
Yeah, yeah. Should I open my slides first and then try to share them?
Yes, please. You have to share, press on that green square and then click on the things that you want to share, your open page.
Okay. Can you see that?
Yes. Wait. Yes, we can see. And
Okay.
yes, if you can make them on presentation mode, please.
Yeah, sure. Okay. Can you see that?
They're still on the, there is this on the right hand corner down.
Yeah. Is that better?
No, it's still on the slide mode. You have a box with an arrow, the start arrow. No, now you have stopped sharing. You have to go back. Even if it's not in the presentation mode, I think that should be fine. But now you have
Okay.
stopped sharing.
Okay, sorry. So you can see that?
Yes. Yes.
Okay, but I'm not sure why
Yes,
I
yes, that,
can't.
yes. If you can press that. No, it's not happening.
No.
Okay, if it's just not happening, then at the right corner down, can you
Yeah,
see
yeah.
one arrow? Even
Yeah.
if you press that, it will come on the full screen. Right hand side corner down. Or if it's okay, you can just go ahead, Dr. Mala, just no issues. We can see
No?
your slides clear. Yes, it's
Okay.
not on full screen. It's still on the slide mode, but that's okay.
So you can see my slide, right?
Yes, we can see your slides.
Okay. Has it moved?
No, we are still on the first slide.
Okay, fine. And now?
No, we are still on the first slide.
Okay. Fine. I may have to do it like this.
Yes,
Can you see this now?
yes,
Yeah.
now, yes,
Okay,
yes,
brilliant.
perfect.
Okay. I'm really sorry about this.
No, that's fine. Please go
Just
ahead. Yes.
okay. Thank you so much. So I'm very grateful to listen and learn from others. So mine is going to be very simple. I'm not going to talk about science behind anaphylaxis. I'm just going to do very practical session, which we face all the time. So then, what is the next step? Once we have dealt with anaphylaxis, acute presentation, our patient is better. So we need to think, this is how I think. So I think this is very helpful to think, who is our patient, whether it's a little infant or pregnant woman or they are adults. And me being pediatrician, I always only see children. And where are we practicing? What resources do we have on our hands to send the patient for further investigations? What sort of education we can give them? For that, do we have resources? And it's very important to make sure that is the patient fully recovered. So sometimes what happens is we think they may have recovered, but that may be a transient recovery. So we need to ensure that have they fully recovered? Are there any investigations which can help towards the diagnosis? And how long to observe? And we heard previously as well that this is a bit of a contentious issue and there's no very clear consensus how long we should observe. But for that, we probably should do some risk stratification. So think about how long to observe. Should we admit them to the ward? When are we going to discharge them? How are we going to prepare the patient for potential further anaphylaxis? And are there contributing factors for the severity of the presentation? So in post-anaphylaxis management, as Dr. Suresh highlighted, that's one situation where you don't jump with A, B, C, D. Rather, if you recognize, you quickly treat them first with adrenaline. But after that, you should definitely do their airway, breathing, circulation, and if there is any disability. So once you have treated acutely, then you ensure that there is complete recovery and do your full set of observations, examine the patient properly to see if there are any other comorbidities. Think about biphasic reaction, and I would enumerate a little bit about that later. What sort of education are we going to give to this patient or their parents, and should we be referring them to specialist allergy services? So when we are dealing with patients who are acutely presenting to our emergency department, there is one investigation which is very helpful. But even in our own hospital emergency department, this is one which might be helpful, but this is the one which is missed. So ideally, they should have mast cell tryptase. And mast cell tryptase being most abundant preformed granular enzyme in the mast cell, it's much easy to measure that because it has also got a longer half-life of about 2 hours. We can attempt to measure histamine, but it has a very short half-life, so it's very difficult to measure. And ideally, it should be measured as soon as the patient comes, and then at 2 hours, and then at 24 hours, and again when they come to the clinic, so you can get a proper baseline. But most of the time, it's never measured, or this may be the first measurement at 1 to 2 hours. That's when it peaks. So if we have measured here, and then if we can measure again at 24 hours, that would be very helpful. But again, it should definitely be measured when they come to clinic fully recovered, so we can establish what is the baseline mast cell tryptase for the patient. Although this is a useful test, but normal mast cell tryptase does not exclude anaphylaxis. So we have to be mindful of this fact. So not over rely on that. Just few words about biphasic reaction. We have already heard from all of the speakers about that, but this is a recurrence of symptoms in the absence of further allergen exposure, and it happens in about 5% of the patients who present with anaphylaxis. But I think this data may be understatement, because I think this is much poorly recognized, and anaphylaxis also getting a proper data on actual anaphylaxis is very difficult. So, but roughly about 5% of the patients get the biphasic reaction. But we have to think about differential. Could this be sustained anaphylaxis with a transient response to adrenaline, and we think that this is biphasic reaction? Or it may be because of allergen absorption from the residual food in the GI tract, or it may be because of the slow release medication if they have come with drug allergy. So that has to be kept in mind. The median time for biphasic reaction is 12 hours, which means that time by which 50% of biphasic reactions have happened, that is 12 hours. So there is no optimum duration for observation. Exactly how long should we keep the patient in the hospital is a little bit not very clear. So we have to think about other factors, such as how severe was the initial presentation? Was initial reaction requiring more than one dose of adrenaline? Or was there delay in administering adrenaline for more than 30 to 60 minutes? And we have seen that time and again, those who have delayed administration of adrenaline, they end up having biphasic reaction. And also we need to think about, was there a previous biphasic reaction in this particular patient? So this is a good framework of risk stratification, which is produced by the UK Resus Council. And I think this is quite helpful to give us some kind of a framework, how long we should keep our patients in the hospital. So if we are seeing a patient in emergency department, and if they responded really well to first dose of adrenaline within 5 to 10 minutes, if they are completely got better, And if they already have one adrenaline with them, which has been previously prescribed, and if there is a adequate supervision at their home, they got extended family to look after them, then we can consider that after 2 hours, if they are fine, we can send them home. Minimum of 6 hours observation is required if these patients have required 2 doses of adrenaline, or if they had previous biphasic reaction. Patients will need a longer observation for 12 hours or even more if their reaction was very severe. So they needed more than 2 doses of adrenaline. If they also have severe asthma, or if their anaphylaxis involved severe respiratory compromise, if there was possibility that the allergen is still continuing to be absorbed, or if the patients are presenting very late at night and they may not be able to respond to any deterioration, or the patients live in an area where the access for emergency care may be very difficult. So we have to take into consideration again where they are coming from, and where I practice medicine is a very large kind of geographical area. So that becomes a very important factor for us to consider when to discharge them. Again, when we are discharge planning, we saw this in the previous slides as well. So during discharge planning, these factors are not only important when you are actually treating the patient, they are important when you are planning to discharge them. For example, age of the patient is very important. If they are infants, sometimes the symptoms of anaphylaxis may not be exactly what we read. So some of the cases, parents have come and said that child suddenly became very sleepy, suddenly became very floppy, looked very pale. So these moms have to be educated that what you saw was anaphylaxis. So age is important. For example, if this is a teenager who have a risk-taking behavior, or pregnant women who may be treated for with antibiotics for infections, or possibly as a prophylaxis to prevent group B sepsis, or it may be elderly patient who are much more at risk of having anaphylaxis to drugs, which we heard previous speaker as well, and also more risk of having venom related anaphylaxis. We should think about comorbidity. Have they got asthma or other conditions where their breathing may be already compromised? Have they got cardiovascular disease? Have they got mast cell activation syndrome or mastocytosis? So I have seen a couple of my patients who have mastocytosis, and we always give them adrenaline pen because they are at a high risk of having anaphylaxis. So that should be taken into consideration. And also, if they got any psychiatric illness, for example, depression, because anaphylaxis already gives you a sense of doom and gloom. And on the top of that, if you already have depression, then you should be probably kept longer. And also the education should be tailor-made for these patients as well. The other factors would be if they are on other medications, and if they got other cofactors. For example, if they do a lot of exercise, they are athletes, a keen sports person, or if they got any acute infection at the time they present with anaphylaxis, or if they got any other emotional stress, or their routine is going to be disrupted because of travel. While you're traveling, you may not sleep, but also travel puts you at risk of not adhering to your the food which you should be avoiding. So all these factors have to be taken into consideration when we are planning discharging the patient. Pre-discharge education is very, very important, and you see all these newspaper article, probably not so much at present in India, but in the UK we see a lot, and you can see these three mums stark warning of how anaphylactic shock and shock signs looked nothing like she expected. So that highlights that the signs and symptoms may vary from child to child. So it's very important to teach them as much as we can without scaring them. Another one was about allergy death, mom flee to school to save lives. And now we have, the schools can buy generic adrenaline auto-injectors, and parents can sign a form to say that if their child has anaphylaxis, school can give the adrenaline to them in the school. And this was another quite recent one where the child had drink from Costa, which the child had milk allergy, and the milk accidentally, unfortunately, was given to the child. So it's our responsibility doesn't stop just at parents. We are, as a stakeholders of treating allergy, our responsibility is way beyond parents, patient. We have responsibility to take it to community, and the list is very long. Who are we going to teach? To paramedics, to first responders, to ambulance drivers, to those who work in the food industry, those who are serving food. And we see a lot of students who come and work in these coffee shops, and they get a minimum allergy training. So they are supposed to ask if patients, if the customers have allergies, but they don't understand the implications, how serious this can be. So we have to teach parents and patients to actually tell about their allergy and be very vigilant. We also should teach them about avoidance of trigger, if we know what trigger possibilities. And these triggers can be hidden allergens. So I never realized that potato crisp can have milk as a hidden allergen. Sometimes the food labeling may not be very clear. Eating out may become challenging. Traveling is again very challenging. So to all my patients, even this is a common sense, I still tell them when I see them that if they are taking air travel, they should take packed lunch from home, not to be very adventurous buying food at the airport or taking the food which they serve in the airline. And simple things like taking some wipe to clean the seat and the tray before they sit down to eat, informing the airline about their allergies well in advance so that they don't serve nuts and common allergens. So that it's a very long list of education we have to give. So for that, we need to take time. And also we should give them a written action plan, which should be individualized. There are action plans available on various allergy websites, but we should individualize that depending on the age of the patient and what they're allergic to. So this is a very nice wheel of discharge planning, which is published by World Allergy Organization. So on the top, you can see that this is the discharge management following an acute anaphylaxis episode, where you are giving them an individualized action plan. You are giving them prescription for adrenaline auto-injector, along with training them how to use it. And also, if you can give the pen, trainer pen. And I was very keen to see the new adrenaline auto-injector, which is developed in India. So I'm hoping that I would be able to see that tomorrow, so that can be tailor-made for the patients who come there. And also these bracelets are helpful in case the patient collapses. Somebody can identify that they have allergy and what allergy they have. Once we have made that, then they should be referred in about 3 to 4 weeks' time to allergy specialist, where further tests can be done based on the history to confirm what sort of allergen they reacted to. So they can either have skin prick test, or they can have specific IgE, or they can have component testing depending on the resources which is available. And once this is done, then we have to educate them again about their own allergen trigger, if they are taking any medications, or if they had allergy to antibiotics. Then there would be next step to send them for a desensitization. And also if this is a sting allergy, then to send them to clinic where immunotherapy, if it is available, send them for that. So post-discharge planning, as I mentioned, involves giving a good written action plan. So this is the action plan which we use, which is from BSACI. And although this is not exactly in line with what we heard about the what is the new definition of anaphylaxis, and it's much more liberal now to say anaphylaxis, and much better to train patients to give adrenaline. And what I say is, if they are in doubt, give it. If you live middle of nowhere where the help can't get, give adrenaline. What we have also done is we have produced QR codes for most of the allergy information leaflet, and then we ask patients, because almost all of them come with their phone, a lot of them have smartphones as well. So if you can convert your information leaflets into QR codes, and they can scan, so it is always there with them to have a look at that and have a revision of that. There are lots of support groups here, but I'm sure as allergy is getting more and more in India, we will also start having support groups, and that may be something as stakeholders we think about how we can encourage communities and parents of the patients to, or patient themselves, if they make a support group, become allergy champions in the community, to spread the good practice and also to keep them safe. And I personally believe that it's all well and good to manage anaphylaxis, teach patients, but we are now moving towards allergy prevention. So that starts from antenatal clinic. So when I teach students or trainees here, I give a lot of emphasis on giving from the last trimester when mom is going to give birth, about breastfeeding, about good skincare for their babies, not to use any commercial product for the baby's skin, and also to how they can start weaning. So at discharge, newborn babies, start giving them information about introduction of allergenic food early, not to unnecessarily avoid food. So how we can more and more quickly progress towards allergy prevention, so that the burden can come down. So I think in India, we are in a good position at the moment before it becomes like a big epidemic of allergy. We start doing allergy prevention already. So this is just a picture of a very pretty place in the Devon, where I live. But I think this depicts your risk stratification. So this is a very nice place, but you can see that this is at the bank of an estuary where there is a lot of water there. All the houses are built a bit on the height. There are lots of boats you see, which people use for a recreational purpose, but they still have a boat so that they can cross. So that's how we need to be prepared for when we deal with anaphylaxis, or when we are dealing with the allergy. And this is another picture. So the one on the right here is where I live, and it's a very huge geographical area, very, very remote. So when patients travel, a lot of time ambulance don't reach, they can't reach there, and paramedics can't reach there. So these patients, I am very liberal giving them adrenaline auto-injectors, and our policy is we give 2 for the child, so it travels with them everywhere. We also give 2 pens to stay at school, so that they don't suffer. And then if they are traveling, especially if they are going to take air travel, I give them 4 adrenaline pens along with antihistamine action plan, and if they have asthma, a salbutamol inhaler as well. And every opportunity, every time they come for follow-up, we go through the training again. So and again, this one is this is thinking way ahead before the water goes over the bridge. We need to be very well prepared. So these are the resources. Dr. Turner has done a lot of work on anaphylaxis and adrenaline pens. And as we heard about the size of the needle, so he's again done a lot of work on that as well. So it's highly recommended in this paper. Anaphylaxis UK, Allergy UK, World Allergy Organizations have wonderful webinars and lots of free resources, whoever wants to access that. Similarly, Allergy Academy also have talking slides, which is free. You just have to register and watch them. And I can't recommend more the book edited by and written by Dr. Neeraj Gupta, the comprehensive textbook of allergy, which is very comprehensive and has excellent information about all aspects of allergy. So I'm going to conclude that. Thank you so much for having me today.
Thank you so much, Dr. Mala, for that wonderful incitement and bringing up the topics like concept of hidden allergens and using simple wipes to clean seats and trays before eating to remove the allergens, and the importance of making support groups. So thank you so much. It was really insightful, and we were really happy to have you here. Thank you for
Thank you
giving
so
us your time. Thank you.
Thank
So
you.
if you can please stop sharing, that would be wonderful.
Sure.
So, last but not the least, we all know Dr. H. Parmesh sir is called the father of allergy in India. He, along with Dr. Professor late Nagaraju sir and Sukumaran sir, they developed allergy in our country. So, unfortunately, we don't have him today because he's in a conference in the USA. But still, we have his recorded version, and he will be giving us an update on the Indian adrenaline auto-injector. So, we would be playing that, and let's see what we have for us as auto-injector adrenaline.
Good evening and good night. At the outset, I extend my sincere thanks to Dr. Neeraj and his team for extending an invitation to interact with all the experts with you all on the subject of anaphylaxis and role of EpiShot in a technical aspect. And I bring greetings from the Deer Park, New York, and also from Institute Indian of Science, Bangalore. You heard all the experts talking prior to me, and still I want to sensitize a few issues before I touch upon the real subject. As you know, anaphylaxis is a serious type 1 hypersensitivity reaction, and it can be fatal if not identified and treated properly on time. And food anaphylaxis is the most common cause for the anaphylactic reaction. We see the clinically various features like skin features having urticaria with intense itching 90% of the time, respiratory symptoms like tightness of the chest and cough 60% of the time, gastrointestinal symptoms 30% of the time, cardiovascular 30%, and miscellaneous 5.8% of the time, such as sense of oppression, nasal, ocular, palatal pruritus, and diaphoresis. How often you see this anaphylaxis globally and all over the world? It has been shown right now from 77 for 1 lakh population earlier, now it is 731 people for 1 lakh population experience anaphylaxis. In Australia, it has been identified in children under 4 years of age. In 99, 19% per 1 lakh population children is to suffer. In 2018, it's gone up to 53.2% of the time. In USA, 16.8% of the population experience anaphylaxis, and 1,200 people visit emergency room department in USA with 200 deaths without getting early injections, adrenaline. And our study shows 15% of the asthmatics have food allergy. The lifetime prevalence of all over the world is 1.6 to 5.1%. European Academy of Allergy and Clinical Immunology in 2017 identified 2 to 4% of the adults and 48% of children among the 8 food what have been shown has been the most common cause. Now, how do you manage? Coming to the subject, of course, any acute anaphylaxis needs an emergency drug at any cost. Adrenaline intramuscularly 0.01 milliliter per kilogram of body weight. It can be repeated in 5 to 15 minutes. And if it is available, adrenaline IV also can be given. However, before you're getting this one, they look for the urgent way of managing this, still giving the humidified oxygen, elevate the legs and supine position, beta agonist inhalation and steroids, beta 2 antiacid when needed, you have to be utilized. After the anaphylactic experience, we have to prepare the patient by having the medical ID band on his wrist. EpiShot they have to carry all the time. and avoiding the allergen, what they're allergic to. See, some of these things, immunotherapy can be given to avoid the anaphylactic reaction for the allergen, what they're used to. Use of adrenaline, any acute allergic reaction, please don't wait for any diagnostic criteria. Please give it. Adrenaline never kill anybody. And this is our EpiShot, what we have done in India. I myself experienced twice near fatal anaphylactic reaction. It took 5 years to develop this one. And how our EpiShot differ from the other competitive market landscapes, what you have, SimJP, Adenolic, EpiPen, OVQ. It varies from $30 to $2,500. How our EpiShot is different? It is affordable. We can produce in India by cost analysis has been done with $5. Ours is reusable, unlike others, and single hand operation is available. Others are not. Level of safety, we are one level higher than the others, and retractable needle, we have been using it, and that's available in EpiPen and OVQ. And ours, it is not available in the market yet because we need a mass production for the marketing. And also EpiPen is another one is available in India in the black market. Now our technology received the national winner for the James Tyson Award. So for the technique, what we have prepared in India. The EpiShot solutions are, it is reusable and cost effective. It reduces the cost of the patient. Doctors, healthcare centers, hospitals administer the drug since the patient does not need to pay for the new injector every time. It is reusable up to 100 times, 1/6 of the cost of the existing alternative in the Indian market. It is portable, a small size that can fit into the purse with 3 levels of safety, such as safety cap avoids accidental shot going into the off while it in the pocket. Contact and shield crown avoids shot going off before it is firm contact with the skin, and automatic needle retraction avoids multiple punctures or painful manual retractions. Who has to carry the EpiShot? These are all the 16 items one can think about it. Whoever had history of systemic allergic reaction to foods and having experienced anaphylaxis, frequent exposure to allergen to profession like latex, venom, and drugs, and systemic reaction to immunotherapy, and insect stings like bee, hive, and yellow jackets, and old age, people with undergoing heart disease, exercise-induced anaphylactic reaction, cold-induced hives, all doctors' kits, all nursing stations, all drug therapy units, all vaccine-administered areas, all cafeteria, all clubs with sports events, all schools, all sports arenas should carry the EpiShot. And this is the team. We have prepared it at 5 years. I am the clinical collaborator and also my dear friend Hardik J. Pandya. He is the assistant professor in the Department of Electronic System in Indian Institute of Science, and his PhD student Arjun and Ajay Krishnan are the one prepared after 5 years of hard effects. And in the July 2024, we got the patenting for the next 20 years. And who has to take home message? All of you. Please note, anaphylaxis is a serious type 1 hyperreaction which can be fatal if you don't treat it properly. Food anaphylaxis is the most common, which can come either by the contact or by inhalation or by ingestion. 90% starts in acute urticaria, angioedema, and intense itching. Adrenaline is the only emergency drug in anaphylaxis. Adrenaline does not kill anyone. Any suspicion, please use it. Patients should wear Medic Alert bracelet. Always check the content of the food. All clinics, hospitals, laboratories, doctors' kits, and restaurants should have adrenaline in the emergency medicine. Keep EpiShot handy. We should influence our stakeholders to bring the technology with cost effectiveness to our needs. Ladies and gentlemen, thank you for your patient ear. Namaste.
That was a wonderful deliberation by Dr. H. Parmesh. And as we all know, we are running short of time. So it was wonderful to know that EpiShot is coming to India, but I think we should wrap up our session. I cannot thank Dr. Neeraj Gupta enough for bringing this concept of learning on anaphylaxis over 3 days. That's wonderful. It's the need of the hour. And thank you all the esteemed speakers, right from Dr. Vikram Patra, Dr. Narayan Modi, Dr. Suresh Gupta, Dr. Mala Raman. She has waited till the end. And of course, our chairperson for the day, Dr. Krishna Mohan. I thank you one and all. And of course, Dr. our esteemed H. Parmesh, sir. I think we can end our session and all our concepts have been wonderfully cleared. So we will meet again tomorrow at 8 p.m.